Basics of Medical Biochemistry. First edition, 2023. Chapter 13. Metabolism of Heme and Porphyrin. By Professor Dr. Muhammad Jawad. MBBS, Dao, M. Philosophy, Ph.D., Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau Medical College Air University, PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. Chapter 13. Metabolism of Heme and Porphyrins. 13.1 Introduction. Heme is found as a prosthetic group of various hemoproteins like hemoglobin, myoglobin, cytochrome C, catalase, etc. Hemoglobin is composed of globin, a protein part 96%, and heme, iron porphyrin 4%. The red color of hemoglobin is due to its heme component. 13.2 Structure of heme. Heme is a coordination complex consisting of an iron ion coordinated to a porphyrin acting as a tetradentate ligand with two axial ligands. In hemoglobin of blood, it is the iron atom that reversibly binds oxygen as the blood travels between the lungs and the tissues. Heme is composed of a protoporphyrin ring and iron, ferroprotoporphyrin. Protoporphyrin is a porphin derivative that has the outer hydrogen atoms in the 4 pyrrole rings replaced by 4 methyl groups CH3, M, 2 vinyl groups CH-CH2, V, and 2 propionyl groups CH2CH2COOH, P. The carbon atoms of methane bridges are designated as gamma and delta. Figure 13.1 Structure of heme, M, methyl, V, vinyl, P, propionyl. The ferrous iron, Fe2+, of heme is bound by coordination bonds with nitrogen atoms of the pyrrole ring. In the hemoglobin formula, the 4 N atoms of the heme ring are considered to be connected to iron by linkage 1, 2, 3, and 4 in the plane of the paper. Linkage number 5 of iron is to the imidazole N of histidine below the plane while linkage number 6 is above it. In the absence of O2, a water molecule is found at valence number 6 of iron. Figure 13.2 Structure of different forms of heme. 13.3 Biosynthesis of heme. It involves the following steps. 1. Formation of delta-aminolevulinic acid, ALA in mitochondria. Succinyl-CoA combines with glycine first to produce an intermediate compound as amino, ketoadipate. It is then converted to delta-aminolevulinic acid, ALA, in the presence of vitamin B6. Pyridoxal phosphate i.e., PLP. Both steps are catalyzed by delta-aminolevulinic acid synthase, ALAS. This enzyme is stimulated by barbiturates and sulfonylureas but decreased by a heme and carbohydrate-rich diet. The formation of ALA is the rate-limiting step in the biosynthesis of heme. Figure 13.3 Formation of delta-aminolevulinic acid, ALA. Clinical aspect. There are 2 isoforms of ALAS. ALAS1 is found universally in all tissues while ALAS2 is found in erythroid tissue only. Deficiency of ALAS2 results in X-linked sideroblastic anemia with iron overload. Common features include fatigue, dizziness, a rapid heartbeat, pale skin, and enlarged liver and spleen, hepatosplenomegaly. Over time, other severe medical problems such as heart disease and liver damage, cirrhosis, can result from the buildup of excess iron in these organs. 2. Formation of porphobilinogen. In the cytosol, 2 molecules of ALA are combined to form porphobilinogen, PBG, which is the precursor of the pyrrole ring. This step is catalyzed by delta-aminolavulinate dehydratase, ALAD, or porphobilinogen synthase. It is a zinc-containing enzyme inhibited by lead. Reduced glutathione is also required for this reaction. Figure 13.4 Formation of porphobilinogen. 3. Formation of hydroxymetylbilane. 4 molecules of PBG are condensed to form a linear hydroxymetylbilane by the cytosolic enzyme uroporphyrinogen I synthase or hydroxymetylbilane synthase. Figure 13.5 Formation of hydroxymetylbilane. 4. Formation of uroporphyrinogen 3. hydroxymetylbilane is converted to the first cyclic compound during heme synthesis known as uroporphyrinogen 3. This reaction is catalyzed by the cytosolic enzyme uroporphyrinogen 3 synthase. Sometimes hydroxymetylbilane spontaneously converted to uroporphyrinogen I, which is a biologically inactive isomer. The uroporphyrinogen I is also converted to uroporphyrinogen 3 by the enzyme uroporphyrinogen 3 cosynthase. Figure 13.6 Formation of uroporphyrinogen 3. 5. Formation of coproporphyrinogen 3. Uroporphyrinogen 3 is decarboxylated in the cytosol by uroporphyrinogen 3 decarboxylase to form coproporphyrinogen 3. 6. Formation of protoporphyrinogen 3 or 9. Coproporphyrinogen 3, formed in the cytosol, is transported to mitochondria. In mitochondria, coproporphyrinogen 3 is oxidized to give protoporphyrinogen 3, 9, by coproporphyrinogen 3 oxidase. 7. Formation of protoporphyrin 3 or 9, protoporphyrinogen 3, 9, is oxidized to give protoporphyrin 3, 9, by mitochondrial protoporphyrinogen 3, 9, oxidase. 8. Formation of heme from protoporphyrin 3, 9 Phe2+ is attached to the nitrogen of the pyrrole ring to give heme. This reaction is catalyzed by mitochondrial heme synthase or ferrochelatase. This step is inhibited by lead, and reduced glutathione is also required for this reaction. Figure 13.7 Steps of heme synthesis. 13.4 Sites of heme synthesis. Heme biosynthesis occurs in most mammalian cells, except mature erythrocytes, which do not contain mitochondria. About 85% of heme synthesis occurs in erythroid precursor cells in the bone marrow and the majority of the remainder in hepatocytes. Subcellular sites include mitochondria and cytosol. 13.5 Regulation of heme synthesis. 1. Regulation of heme synthesis in the liver. The delta-aminolevulinic acid synthase, ALAS, is the key regulatory enzyme. Its activity is enhanced by high iron contents as well as by certain drugs like barbiturates and some cytotoxic drugs, but they need cytochrome P450 for their metabolism. ALAS is inhibited by heme feedback inhibition. Heme represses the ALAS1 and affects the transport of ALA enzyme to the cytosol. Hemidin, oxidized heme, also has an allosteric inhibitory effect on ALAS. ALA dehydratase and ferrochelatase are inhibited by lead. 2. Regulation of heme synthesis in bone marrow. Erythropoietin stimulates heme synthesis. Erythropoietin is synthesized by the kidney in response to hypoxia. ALAS2 is not a rate-limiting enzyme. It is neither affected by heme nor by drugs. However, ferrochelatase and iron uptake may affect heme synthesis. 13.6 Catabolism of heme. Red blood cells are continuously undergoing the hemolysis, breaking down, process. The average lifetime of a red blood cell is 120 days. Red cells which lyse while circulating in the blood vessels are catabolized by a process known as intravascular hemolysis. Normally only a small portion of RBC breakdown occurs in this manner. When normal erythrocytes come to the end of their lifespan, they are removed from the bloodstream by reticuloendothelial cells, i.e., macrophages, through a process known as extravascular hemolysis. The chief site of phagocytosis is the spleen, but in hemolytic disease, the liver and bone marrow also assume this function. As the red blood cells disintegrate, the hemoglobin is degraded or broken into three components: globin, the protein part, iron, and porphyrin part. 1. Globin, it is either degraded to amino acids or reused for the synthesis of hemoglobin. 2. Iron, it is reused in the synthesis of hemoglobin and other iron-containing substances. The extra amount of iron is stored in reticuloendothelial cells. 3. Porphyrin part, porphyrin ring of heme is broken down in reticuloendothelial cells of the liver, spleen, and bone marrow to bile pigments, mainly bilirubin. About 250 mg of bilirubin is produced from 6 g of hemoglobin breakdown daily. Myoglobin and other heme-containing proteins give 50 mg of bilirubin daily. So, the total amount of bilirubin produced daily is 300 mg. Steps of heme catabolism to give bilirubin. following steps are involved in the formation of bilirubin and other bile pigments during the catabolism of heme. 1. Formation of biliverdin from heme. Biliverdin is the first bile pigment derived from heme, which is green in color. It is produced from heme after the loss of one molecule of Co and one ferric iron atom, Fe3+. This reaction takes place in the microsomal fraction of reticuloendothelial cells in the presence of the enzyme heme oxygenase. This enzyme needs oxygen and NADPH plus H plus along with cytochrome P450 and flavoprotein. Heme acts as an inducer for heme oxygenase. During this reaction, the porphyrin ring is cleaved at the alpha-methynyl bridge between pyrrole rings I and II by oxidation. 2. Formation of bilirubin from biliverdin. Bilirubin is the main bile pigment. The formation of bilirubin is an intracellular process. Bilirubin is yellow in color and produced from biliverdin by the action of the cytosolic enzyme biliverdin reductase in the presence of NADPH plus H+. Bilirubin is not only derived from senile RBCs but also from those resulting from ineffective erythropoiesis as seen in pernicious anemia, thalassemia, lead poisoning and erythropoietin porphyria, etc. About 20 to 30% of bilirubin is derived from other heme-containing substances like myoglobin, catalase, cytochromes, etc. Bilirubin is a nonpolar hydrophobic substance. Bilirubin passes out of the cell into the blood where it is bound to albumin reversibly and non-covalently. About 25 mg of bilirubin can bind with albumin present in 100 ml of plasma. In this form, the bilirubin is unconjugated and indirectly reacting. Bilirubin does not appear in urine because it cannot filter into renal glomerular filtrate being complexed with albumin. Figure 13.8 Formation and conjugation of bilirubin, M, methyl, V, vinyl, P, propionyl. 3. Formation of bilirubin diglucuronide, conjugated bilirubin. Unconjugated bilirubin is cleared rapidly from the blood by the parenchymal cells, hepatocytes, of the liver. The hepatocyte uptake of unconjugated bilirubin at their sinusoidal surface is carried out by a facilitated transport system. Inside the hepatocyte, bilirubin is bound to cytosolic anion-binding protein example ligandin, glutathione-transferase B, which prevents the efflux of bilirubin back to plasma. Now inside the hepatocytes, bilirubin is conjugated with a solubilizing sugar called glucuronic acid by the enzyme glucuronosyl, glucuronyl, transferase. This form of bilirubin is called conjugated or direct bilirubin. In the conjugated form, it is secreted into the bile ducts of the liver and passes into the small intestine through the common bile duct. First, bilirubin is conjugated with UDP, uridine diphosphate, glucuronic acid to form bilirubin monoglucuronide by glucuronosyl transferase. Bilirubin plus UDP glucuronic acid bilirubin monoglucuronide plus UDP. Bilirubin monoglucuronide reacts with another molecule of UDP glucuronic acid to form bilirubin diglucuronide. The reaction is catalyzed again by the same enzyme i.e., glucuronosyl transferase. Bilirubin monoglucuronide plus UDP glucuronic acid bilirubin diglucuronide plus UDP. Some amounts of bilirubin diglucuronide are also produced by following a reaction catalyzed by dismutase. 2. Bilirubin monoglucuronide bilirubin diglucuronide plus bilirubin. 4. Formation of urobilinogen and urobilin. This is produced by the action of intestinal bacteria in the terminal ileum and colon. Conjugated bilirubin is deconjugated from glucuronate and then reduced to urobilinogen or stercobilinogen, colorless, substance. Most urobilinogen, 80 to 90%, are oxidized to stercobilins and excreted in feces. The characteristic brown color of stool is due to these stercobilin pigments. Normally small amounts, 10 to 20%, of urobilinogen are reabsorbed by portal blood and excreted by liver cells into bile, enterohepatic circulation, and traces escape and are excreted in urine as urobilin after oxidation. The characteristic yellow color of urine is due to these urobilin pigments. The oxidation of urobilinogen and stercobilinogen to urobilin and stercobilin probably occurs chiefly when excreta are allowed to stand and exposed to air. Examinations for urobilinogen and stercobilinogen must be carried out on freshly passed specimens. Figure 13.9 Oxidation of stercobilinogen to stercobilin and urobilin. 13.7 Bilirubin derivatives in urine. 1. Bile pigments in urine. Bile pigments are normally absent in urine as the circulating bilirubin is unconjugated and, therefore, insoluble in water. The presence of bilirubin in urine indicates that conjugated bilirubin is present in circulation. This occurs in hepatocellular and obstructive jaundice. 2. Urobilinogen in urine. Urobilinogen is formed in the gut by the action of intestinal bacteria on bilirubin. Most of it is excreted into feces after being converted to stercobilinogen and then stercobilin. Some of it is absorbed into the portal circulation and is brought to the liver, which re-excretes most of it. The remainder passes into the urine. In obstructive jaundice, no bilirubin enters the gut, no urobilinogen is formed and, therefore, there is no urobilinogen in the urine. In hemolytic jaundice, urinary urobilinogen is increased while it is usually normal in hepatocellular jaundice. 3. Bile salts in urine. Bile salts are normally not present in detectable quantities in urine. Their presence in urine denotes the regurgitation of bile into circulation. Thus, bile salts are found in the urine in obstructive and hepatocellular jaundice. Figure 13.10 Excretion of bilirubin. 13.8 The porphyrias, disorders of porphyrin metabolism. The word porphyria is derived from Greek, meaning purple, refers to the red-blue color of urine due to the presence of pigment like porphyrin. Porphyrias are the metabolic disorders of heme synthesis, characterized by the increased excretion of porphyrins or porphyrin precursors. Porphyrias are either inherited or acquired. The main causes are enzyme deficiencies that lead to heme pathways intermediates accumulation. The most common acquired form of porphyria is due to lead poisoning. Classification of the porphyrias. 1. Multiple ways to categorize porphyrias. Hepatic vs erythropoietic. It is based on the organ in which the accumulation of porphyrins and their precursor appears. In erythropoietic porphyrias, enzyme deficiency occurs in erythrocytes, while in hepatic porphyrias, enzyme defect is found in the liver. Cutaneous vs non-cutaneous. Acute and non-acute, chronic, forms. 2. Acute porphyrias. Aminolevulinic acid dehydratase deficiency porphyria, ALDP. Acute intermittent porphyria, IPE. Hereditary coproporphyria, HCP. Variegate porphyria, VP. 3. Chronic porphyrias. Porphyria cutanea tarda, PCT. Erythropoietic protoporphyria, EP. Congenital erythropoietic porphyria, CEP. Hepatoerythropoietic porphyria, HCP. Demonstration of porphyrin precursors, such as ALA and or PBG, is essential for the diagnosis of acute porphyrias. Porphyrin analysis is necessary for the diagnosis of porphyrias with cutaneous photosensitivity. Treatment is based on large amounts of glucose administration and intravenous infusion of heme once daily for 4 days, during acute attacks. It is important to avoid precipitating factors such as causing drugs and sunlight. Ingestion of provitamin A, beta-carotene, is also helpful as it scavenges free radicals. Repeated phlebotomies are the treatment of choice in porphyrias with photosensitivity. 13.8.1 Porphyria cutanea tarda, PCT. It is a chronic hepatic, autosomal dominant, and the most common porphyria. It is caused by a deficiency of uroporphyrinogen decarboxylase, which is involved in the conversion of uroporphyrinogen 3 to coproporphyrinogen 3. Symptoms usually appear in the 4th or 5th decade of life. It is associated with liver damage caused by alcohol overconsumption or iron overload. Liver biopsy exhibits fluorescence due to the high concentration of accumulated porphyrins. Uroporphyrin appears in the urine. Patients are photosensitive, cutaneous photosensitivity. Figure 13.11 Skin condition in Porphyria cutanea tarda, PCT. 13.8.2 Acute intermittent porphyria, IPE. It is a rare autosomal dominant metabolic disorder affecting the production of heme resulting from a deficiency of the enzyme hydroxymethylbilane synthase, porphobilinogen deaminase. It is the most common type of acute porphyrias. The prevalence of IPE is 5 to 10 per 100,000, in the USA. Women are affected more than men, with a ratio of 2:1. Most patients become symptomatic at age 18 to 40 years. Signs and symptoms of acute porphyria may include severe abdominal pain, pain in the chest, legs, or back with weakness and paralysis, constipation or diarrhea, nausea and vomiting. ALA and PBG accumulate in the urine. PBG in urine is oxidized to porphobilin upon standing, which gives a dark brown color to urine, and is often referred to as port wine reddish urine. Neuropsychiatric disturbances, anxiety, confusion, hallucinations, and disorientation, occur due to reduced activity of tryptophan pyrrolase, caused by depleted heme levels, resulting in the accumulation of tryptophan 5-hydroxytryptamine. Sudden death may occur, presumably due to cardiac arrhythmia. Molecular diagnostic testing, detection of porphobilinogen deaminase mutations in IPE provides 95% sensitivity and around 100% specificity. Possible to screen asymptomatic gene carriers but less useful in acute attacks. 13.8.3 Erythropoietic protoporphyria, EPID is the most common childhood porphyria. It is a chronic autosomal dominant type of porphyria. It is usually evident by 2 years of age. It is due to a deficiency of the enzyme ferrochelatase. This condition is characterized by abnormally high levels of protoporphyrin in the red blood cells, erythrocytes, plasma, skin, and liver. The main clinical features are skin pain in sunlight, erythema, swelling, scarring, blistering and waxy thickening. Complications include anemia, gallstone, and liver failure. Skin biopsy exhibits red fluorescence. 13.8.4 Congenital erythropoietic porphyria, CEP, or Gunther's disease. It is a very rare autosomal recessive disorder. It usually occurs during infancy and is rarely present in adult life with milder forms. It is caused by the deficiency of the enzyme uroporphyrinogen 3 synthase. The main clinical features are very severe photosensitivity with phototoxic burning and blistering leading to mutilation of light-exposed parts. Erythrodontia, red discoloration of teeth. Scleromalacia perforans, dry eye. Enlarged spleen. Hemolytic anemia. Thrombocytopenia. Lab findings are elevation of uroporphyrinogen I in urine and coproporphyrinogen I in urine as well as in stool. 13.8.5 Hereditary coproporphyria, HCP. It is an autosomal recessive disorder due to a deficiency of the enzyme coproporphyrinogen 3 oxidase. Incidence is very rare and usually appeared at the age of 1 year. Patients are photosensitive, and abdominal pain and neuropsychiatric symptoms are also present. Lab findings include raised urinary ALA, PBG, and coproporphyrin 3. Fecal coproporphyrin 3 is also increased. 13.8.6 Variegate porphyria, VP. It is an autosomal dominant disorder. It is due to defects in the protoporphyrinogen oxidase gene. This disorder begins after puberty in the second and third decades of life. Incidence is most common in South African whites at 1:330, elsewhere is 1:50,000 to 100,000. Male to female ratio is equal. Prenatal diagnosis is possible by DNA analysis. Skin problems are identical to PCT with bullae, erosions, skin fragility, scarring, hypertrichosis and hyperpigmentation. Gastrointestinal symptoms include colicky, abdominal pain, nausea, vomiting and constipation. CNS symptoms are peripheral neuropathy with pain, weakness, and paralysis. A state of confusion also occurs with anxiety, depression, delirium, seizures, and coma. Cardiovascular complaints include tachycardia and hypertension. Urine ALA and PBG levels are increased during attacks. Fecal porphyrin levels are markedly elevated. Protoporphyrin coproporphyrin. 13.8.7 Acquired or toxic porphyria. It occurs due to the toxicity of several toxic compounds like hexachlorobenzene and drugs like grizofulvin. Exposure of the body to heavy metals, example lead, may also cause acquired porphyria. These agents inhibit many enzymes in heme synthesis. These include ALA dehydratase, uroporphyrin I synthase and ferrochelatase. Table 13.1 Important characteristics of some porphyrias. Type of porphyria. Classification. Deficient enzyme. Features. Porphyria cutanea. Tarda, PCT. Hepatic. Uroporphyrinogen decarboxylase. Autosomal dominant. Uroporphyrin in urine. Patients are photosensitive. Acute intermittent. Porphyria, IPE. Hepatic. Hydroxymethylbilane synthase. Porphobilinogen deaminase. Autosomal dominant. ALA and PBG in urine. Mental problems present. No photosensitivity. Erythropoietic. Protoporphyria, EP. Erythropoietic. Ferrochelatase, heme synthase. Autosomal dominant and recessive. Protoporphyrin in the red blood cells, erythrocytes, plasma, skin and liver. Patients are photosensitive. Congenital. Erythropoietic porphyria. SEP. Erythropoietic. Uroporphyrinogen 3 synthase. Autosomal recessive. Severe photosensitivity. Uroporphyrinogen I in urine. Coproporphyrinogen I in urine as well as in stool. Hereditary. Coproporphyria, HCP. Hepatic. Coproporphyrinogen 3 oxidase. Autosomal dominant. Patients are photosensitive. Abdominal pain and neuropsychiatric symptoms are present. Raised urinary ALA. PBG and coproporphyrin 3. Increased fecal coproporphyrin 3. Variegate porphyria. Hepatic. Protoporphyrinogen oxidase. Autosomal dominant. Patients are photosensitive. ALA and PBG levels are increased in urine. Fecal porphyrin levels are markedly elevated. Summary. Heme is a coordination complex consisting of an iron ion coordinated to a porphyrin acting as a tetradentate ligand with two axial ligands. Heme is found as a prosthetic group of various hemoproteins like hemoglobin, myoglobin, cytochrome C, catalase, etc. The majority, 8%, of heme biosynthesis occurs in erythroid precursor cells in the bone marrow and the majority of the remainder in hepatocytes. The delta-aminolevulinic acid synthase, ALAS, is the key regulatory enzyme in heme biosynthesis. Its activity is enhanced by high iron contents as well as by certain drugs like barbiturates. Red blood cells disintegrate at the age of 120 days. The hemoglobin is degraded into three components: globin, the protein part, iron, and porphyrin part. The porphyrin ring of heme is broken down in reticuloendothelial cells of the liver, spleen, bone marrow to bile pigments. Biliverdin is the first bile pigment derived from heme, which is green in color. Bilirubin is the main bile pigment. It is yellow in color and produced from biliverdin by the action of the enzyme biliverdin reductase in the presence of NADP plus H+. Inside the hepatocytes, bilirubin is conjugated with glucuronic acid by the enzyme glucuronil transferase. This form of bilirubin is called conjugated or direct bilirubin. By the action of intestinal bacteria, conjugated bilirubin is deconjugated and then reduced to urobilinogens or stercobilinogen, colorless, substances. Most urobilinogens, 80 to 90%, are oxidized to stercobilins and excreted in feces. Normally small amounts, 10 to 20%, of urobilinogen are reabsorbed by portal blood and excreted by liver cells into bile, and traces escape and are excreted in urine as urobilin after oxidation. The characteristic yellow color of urine is due to urobilin pigments. Porphyrias are the metabolic disorders of heme synthesis, characterized by the increased excretion of porphyrins or porphyrin precursors. The main causes of porphyrias are enzyme deficiencies that lead to heme pathways intermediates accumulation. Porphyria cutanea tarda, PCT, is a chronic hepatic, autosomal dominant, and the most common porphyria caused by a deficiency of uroporphyrinogen decarboxylase. The most common acquired form of porphyria is due to lead poisoning. References. Exercise questions. MCQ 1. In heme biosynthesis, delta-aminolavulinic acid is produced by a reaction of succinyl-CoA with which of the following amino acids? Alanine, arginine, glycine, leucine, lysine. MCQ 2. Which of the following enzymes is involved in the conversion of heme into biliverdin during heme catabolism? Dehydrogenase, oxidase, oxygenase, peroxidase, reductase. MCQ 3. 12. A 45-year-old woman presented with complaints of progressive photosensitivity, evident by the appearance of blisters on the skin that's exposed to the sun, including the hands, face, and arms. She was diagnosed with porphyria cutanea tarda, PCT, based on relevant laboratory tests. Which of the following enzymes is deficient in this patient? Coproporphyrinogen oxidase, hydroxymethylbilane synthase, porphobilinogen deaminase, protoporphyrinogen oxidase, uroporphyrinogen decarboxylase. MCQ 4. A 10-month-old boy is presented with failure to thrive and persistence of anemia. Blood analysis revealed to be twice the level deemed toxic. Lab results showed raised levels of lead in the blood and high levels of coproporphyrinogen 3 in the urine. Which of the following enzymes of heme biosynthesis is inhibited maximally in this patient? Delta-aminolavulinic acid, ALA, dehydratase. Delta-aminolavulinic acid, ALA, synthase. Ferrochelatase. Porphobilinogen, PBG, deaminase. Uroporphyrinogen decarboxylase. MCQ 5. A 35-year-old woman presented with jaundice and scleral icterus. She is diagnosed with paroxysmal nocturnal hemoglobinuria. Which of the following metabolites would be increased in the urine of this patient? Bile, conjugated bilirubin, stercobilin, unconjugated bilirubin, urobilinogen. End of Chapter 13. Thank you.